Good day to all. Welcome to Dentistry and more. So today's discussion is about the question paper discussion on oral medicine and radiology. So the topic that will be discussed under this discussion will be the chapter on red and white lesions. So it's the bread and butter of oral medicine that we should know about red and white lesions in and out. So most commonly the questions will be asked related to this topic. So the long essays that have been asked in this topic is the classification of red and white lesions, and also to discuss in detail about the etiology, clinical features and management of oral lichen planus. So how to go about for the classification of red and white lesions? It has been given in Burkitt's in the 12th, 11th, as also the previous editions of Burkitt's oral medicine textbook. And also it's been given in your Anil Gomes textbook of oral medicine as well as in Ravi Kiran Ongol textbook of oral medicine. So based on the etiology, how it can be classified is first and foremost is the normal mucosal variations, which are leukoedema, phoresis granules, and then the linea alba bacalis. And inherited or the genetically linked white keratotic lesions are oral genodermatosis, white spongy nevus, Pachyonychia congenita, and then the hereditary benign intraepithelial dyskeratosis. All the inflammatory reasoned out white lesions are the traumatic keratosis, mechanical trauma, thermal burn, chemical burn, as well as the radiation mucositis. Then the red and white lesions that are caused due to infections, which can be caused due to any bacterial or fungal infections. These are the syphilis, measles, oral candidiasis, and bacterial stomatitis. Premalignant lesions such as that of Leukoplakia, Erythroplakia, then the premalignant conditions such as oral submucous fibrosis, hydropenic dysphagia, syphilitic glossitis. Then the next one is under the cause of immunopathological reasons such as the oral lichen planus and the lichenoid reactions, followed by miscellaneous ones which you can enlist the hairy tongue as well as median rhomboid glossitis. Then the next classification is based on the non-scrapable as well as the scrapable lesions. So you have non-scrapable lesions, which are these enlisted here. That is the linea alba bacalis. Then you have the homogeneous leukoplakia, reticular lichen planus, frictional keratosis, dyskeratosis congenita, white spongy nevus, and then the chronic hyperplastic candidiasis. The scrapable ones are the chemical burn or the thermal burn, pseudomembranous candidiasis, the diphtheritic patch, as well as a syphilitic mucus patch. Followed by the next sub question related to this is the discussion in detail about the etiology, clinical features, and the management of lichen planus. As you know, lichen planus is an autoimmune disorder. It's a chronic inflammatory autoimmune disorder that can affect the skin and the oral mucosa. So at first and foremost, to enlist the etiological factors, you can state that first and foremost it is unknown etiology. It is most commonly an autoimmune disorder, so it is a T cell mediated disorder. The explanation of the pathogenesis of this T cell mediated disorder is being explained well in Burkitt's itself. You can read it under the red and white lesions chapter, where under the lichen planus topic itself, and even in the lichenoid reaction, there is a picture depicting the etiopathogenesis of as how the cytotoxic T cells have been affected in this lesion. So the triggered factors are the genetic as well as environmental and any other lifestyle factors, and even it also plays a psychological factor such as that of extreme levels of anxiety as well as stress can lead to this condition. Moving on to the clinical features. First and foremost, when you enlist the clinical features in any topics itself, you start off with the epidemiological reasons. That is the male, is it affecting the males or the females? That is a gender predilection. Then you go about with the age predilection, and then you speak about the clinical appearances. So the epidemiological characteristics, that is the age factor. It is commonly seen around 40 to 70 years of age in lichen planus cases, and then female predilection is being seen in lichen planus. And then you should highlight about the main feature, that is the clinical appearance of the classic feature that you see in lichen planus is Wickham's striae. So Wickham's striae is nothing other than a lacy like radiating lines that you see almost like a spidery web as seen here on the buccal mucosa. That has been there are striations that are seen over the buccal mucosa it has been affected. Most common sites in oral mucosa that lichen planus is affected is around the buccal mucosa, the labial mucosa, as well as the tongue and the palatal region. Even at times it also involves a gingiva too. So when, and you know that this lichen planus, it affects not only the oral mucosa. First and foremost, it starts as a skin lesions itself. So in the skin lesions you can see that the skin involvement, that there are so many subtypes. Unlike our oral mucosa, there are so many subtypes of around 32 types of skin lesions are there in lichen planus. So once you start off, you can talk about the 6 P's in skin lesions. That is it is planar, it is purple, polygonal, periodic, papules and plaques are seen in skin type of lichen planus. And then you can speak about these skin involved clinical appearance, such as it is itchy, it is violaceous to brown papules, alopecia is seen, especially involving the scalp. And then you can speak about when it has been involved with the nail beds. You can say that there is onychorexis and also onychoschisia. Onycholysis, that is again the breakage of the nail beds, and then pterygium, then the anochia, and the Cobner's phenomenon is highlighted on the skin lesions. And then when you're speaking about the oral manifestations, you have to speak about the 6 types that are seen in your oral mucosa. That is the reticular, papular, plaque type, erosive, atrophic, as well as the bulbous are the types that are seen, which is being given by Anderson in 1968. And you can see that if you refer in Burkitt's oral medicine itself, the 6 types has been emphasized about it. What are the appearances that you see in each of the type? So most commonly seen lichen planus lesions, that is a white lesion, predominantly white lesion that you see is the reticular type. And then when you go about the mixed lesion, that is a red and white lesion, you go for the atrophic or the erosive type of lichen planus that is being seen. So you should highlight each feature, each clinical appearance that you see in each type. So while speaking about the management of oral lichen planus, it will be much preferred to draw a flowchart. This flowchart has been taken up from the textbook of Ravikiran Ongol, in which you have enlisted of what kind of treatment has to be done in regard to each case, each lesion or each type of lichen planus that has been seen. So if you draw a flowchart, you can state that here you can see that the management is done by the help of, first and foremost, we try to do with the antifungal therapy so as to eradicate. There is no predisposition of any candidal hyphae in such cases. So if in case it responds to this antifungal therapy, then we don't have to go further down to the corticosteroid therapies. If in case there is no symptom relief to antifungal therapy, then we move forward to topical application of the corticosteroids, or else even also the combination of systemic as well as topical application. So this is how we go about for the management of lichen planus. And then there are further alternative therapies, such as that of you give certain alternative therapies like aloe vera and curcumin and all those things, which have immunomodulating factors as to reduce the symptoms as well as to reduce the lesions growth. So by highlighting each of these drug application, then by this flowchart itself is very self-explanatory to the examiner that you have learned all about the how to manage a lichen planus case itself. If you can elaborate few points in regard to each of the immunomodulators, such as that of chloroquine, what is the dosage and how many months are being given, what is the action mechanism of action for each of these drugs, then it is self-sufficient that you will gain your marks for that question. Next, moving on to what is the definition of white lesion, then the classification of oral white lesions, and then you have to describe the etiology, clinical features, diagnosis, as well as the management of oral cancer. So oral cancer as such, that is a different chapter that we'll be talking about. In this, sometimes there will be a combination of the questions. There will be a combination of this question with the white lesion as such. So I will highlight the points in regard to how to go about to answer such a question. So how to go about the definition for white lesion? White lesion is a non-specific term used to describe any abnormal area of the oral mucosa that on clinical examination appears whiter than the normal surrounding tissue. It is usually slightly raised, roughened, or of different texture from the adjacent normal mucosa, such as that of Lialinea albumbacales, frictional keratosis, Leukoplakia, and chronic hypoplastic candidiasis are the examples that you can cite upon. So, how to go about the classification of oral white lesions? I have already previously answered that question. That is based on the etiology, then followed by the based on whether it's scrapable or non-scrapable white lesion, that you have to enlist the lesions itself. Then moving on to the question in regard to oral cancer. What are the etiology? As you know, etiology for oral cancers are mostly due to any habits, adverse habits that have been intaken by the patient. So that is tobacco, smoking, as well as alcohol predisposition is also seen in the etiological factor for oral cancer. Then there are other nutritional factors even also cause due to trauma, also due to irregular teeth itself. The traumatic factor can lead to the oral cancer itself, and also any restorations, even cheek biting habits, sun exposure due to the exposure to UV light itself, and also in some syndromes or some conditions such as that of systemic condition, that of Plummer-Vinson disease. So moving on to the clinical features for the oral cancer, as I've already earlier stated that you have to enlist the epidemiology of the clinical case. So you start off with the age factor, the predilection, and then you talk about the location or the sites itself. In this, the common sites that is seen for oral cancer is the lower lip, then the anterior floor of the mouth, the lateral borders of the tongue, and that you should specify that there is a more malignant transformation that is seen on the floor of the mouth and also the lateral borders of the tongue, especially the ventral aspect of the tongue. That should be highlighted in the clinical features itself. And then you can speak about how the lesions appear. It appears as a flat or elevated, ulcerated or non-ulcerated. It can also be a palpable, indurated kind of a based lesion. And then you speak about the clinical features such as that of there is discomfort, dysphagia, odinophagia, otalgia, limited movement, especially if it is tongue involved. Definitely your tongue protrusive and the lateral movements are limited. And then you speak about the oral bleeding, as well as there are certain masses, especially when you palpate the lymph. When you speak about the neck masses, again, when you involve with the lymph nodes, there will be cervical lymphadenopathy seen in such conditions, and also there is weight loss or even fatigue seen in such patients. Then moving on to the investigations of it, you can state the investigation, the imaging that has been done, especially the advanced imaging that has been used, the CT, MRI, and also ultrasound images that has been taken, and also the scintillating scans that has taken with the nuclear medicine itself. You can talk about that, and also you speak about the surgical approach, that is once you try to excise or biopsies that have been done, you can take the biopsy of such cases and then followed by a histopathological reporting. Based on that, there are certain criteria for oral dysplasia, that if you can mention this histological features or the criteria for stating that there is oral dysplasia, then you can clearly fetch marks for this investigation part. Then followed by the treatment aspect. Treatment aspect, that is the conventional method, that is surgery itself has been done, and then followed by the radiotherapy, the chemotherapy, sometimes a combination of both, that is the radiation, surgery, as well as chemotherapy that has been done, and then followed by gene therapy and immunotherapy. These can be emphasized, or if you want to elaborate these points, you can read from the textbook itself for oral medicine in Ravikiran Ongol under the topic oral cancer itself. They have highlighted and specified how to elaborately answer in regard to this. Next question is about the enumerate white lesions of the oral cavity and discuss the clinical features, investigations, and management of Leukoplakia. So again, I think this is going to be repeated over and over again in regard to red and white lesions. They will definitely, it's a favorite question to be asked, was the classification. So you should definitely read about it, the classification that is based on the etiology, then followed by the scrapable and non-scrapable lesions that have been enlisted previously itself. The same thing you have to answer here also again. And then coming on to the Leukoplakia. So how to go about is the etiology. If they ask about Leukoplakia, definitely the etiology is nothing other than the adverse habits that the patients take, that is the intake of smoking, the tobacco usage, as well as the predisposition of alcohol also can lead to this condition. So you have to speak about that, and then followed by the clinical features, that is first and foremost age predilection, that is it is seen in the middle-aged as well as the older age group. And then when speaking about the gender predilection, there is male is to female ratio is found to be 3:1 to 6:1 is the range. And then followed by the clinical features or the clinical appearance that you see. When you talk about the clinical appearance, you say that the classic appearance that you see in a leukoplakia is a cracked mud appearance. Cracked mud appearance, why did you state that? If you see normally in a paddy field itself, when you see a dry land, there will be these cracks that you see within the soil surface itself. That is what it is, the similarity. This appearance is looking similar to that kind of an appearance. That is why it's called as a cracked mud appearance. So here in leukoplakia, the site preferably that is seen is the buccal mucosa, followed by the labial mucosa, alveolar mucosa, the floor of the mouth, and then the lateral borders of the tongue, as well as the labial mucosa I have already mentioned. And sometimes you can see it in the vermilion border of the lip, as well as even in the palatal mucosa. So the early stages of leukoplakia that you see is a slightly elevated grayish white plaque. I hope you will read about what is a plaque definition. It's already given in the textbook of Burkitt's itself. They have enlisted 10 definitions for each of it. That is what is plaque, what is papule, and all. So if you go about it and if you read about this definition, it will be helpful not only for your answering your question in your theory based as well as practical based. When they ask viva, they ask these kind of definitions too. So I request you all to read about that, and then followed by, if you answer these questions, that is when asked about leukoplakia, definitely you should say that it is a white plaque lesion, and then it progresses to thicker and whiter surfaces. Then you see that sometimes there are certain types of leukoplakia, that is a nodular type, and then you have a verrucous kind of a leukoplakia. And there are two major types of clinical forms that you see, is a homogeneous as well as a non-homogeneous leukoplakia. So you have to specify in each type itself what are the features that you see. And in homogeneous, it's mostly predominantly a white lesion. In non-homogeneous, it's a mixed lesion, that is a red and white lesion that you see. And under that, subtypes are these kind of verrucous leukoplakia. Verrucous leukoplakia, as the name suggests, is more of an exophytic growth that you see. Verrucous type, it's more of it has a more malignant transformation rate than compared to any other types in the leukoplakia. So such cases has to be dealt vigilantly. And next is the investigations that you go about for leukoplakia. And investigations of leukoplakia, first and foremost, we start off with the chairside investigation. That is the vital staining that we do is the toluidine blue staining. I will be explaining further on how to go about in the toluidine blue staining and all. Then you go about for the biopsy of that is the excisional or the incisional biopsy of that site, and then followed by the histopath reporting of it. And then you have a cytobrush technique also, that is also again coming under the biopsy topic itself. And these are the investigations that we do in regard to leukoplakia. As I mentioned for the previous slide on talking about the lichen planus itself, it's better always when you're asked a question in regard to management of any red and white lesions, always start off with a flow chart and then you explain each of the points, that is each of the treatment protocol that you follow by. So once you give this kind of flow chart itself, it is self-sufficient and explanatory to the examiner itself that you have gone about this kind of a management protocol for treating the lesion. So this is how you'd write about the management of leukoplakia case, and this flowchart has been given in the textbook of oral medicine by Ravikiran Ongol. Again, even in your textbook of oral medicine by Burkitt's itself, even in that also they have given a flowchart. Either of these two flowcharts is sufficient to answer this question of management of oral leukoplakia. How to go about the classification of oral candidiasis? The classification is given in the textbook Burkitt's Oral Medicine. There are two types, that is a primary as well as a secondary candidiasis. Under the primary candidiasis, you have the pseudomembranous candidiasis, erythematous candidiasis, followed by hyperplastic candidiasis. Under the hyperplastic candidiasis, you have two subtypes, that is a plaque type as well as a nodular or the speckled candidiasis. Then followed by the candida associated lesions such as dengue-stomatitis, angular cheilitis, and then the median rhomboid glossitis. Next is the secondary candidiasis. Under that, you have all the systemic conditions such as that of familial chronic mucocutaneous candidiasis, diffuse chronic mucocutaneous candidiasis, candidiasis endocrinopathy syndrome, familial mucocutaneous candidiasis, severe combined immunodeficiency, DGeorge syndrome, chronic granulomatosis disease, then acquired immunodeficiency syndrome. So these come under secondary candidiasis. So next sub question is the write in detail about pseudomembranous candidiasis as well as its management. So first and foremost, we should present with the how does it clinically appear pseudomembranous candidiasis. That is, it is found to be a white curdy-like removable plaque. Removable plaque meaning it can be also it is a scrapable lesion. So once you scrape out this plaque, then you will be left behind with the erythematous area. So the pseudomembranous candidiasis is found to be a common most form of oral candidiasis, and the most primary locations that are seen in site of the pseudomembranous candidiasis is the buccal mucosa, dorsal part of the tongue, as well as the palatal mucosa. And the etiology behind the pseudomembranous candidiasis is due to the prolonged intake of antibiotic therapy as well as immunosuppressive drugs by the patients, and also it is seen and associated with the HIV patients itself. Next is the management of the oral candidiasis or even pseudomembranous candidiasis as such. You can give this kind of a flowchart. This flowchart has been given, it's been dictated in the textbook of oral medicine by Ravikiran Ongol itself, and sometimes there might be a question as short essays itself. They can ask a question related to antifungal therapy. If you go about in this flowchart itself, you can see all the antifungal drugs that have been enlisted here with the dosage as such. So if you go about the same way and in explaining the answer for antifungal therapy itself, you can fetch marks for that. And if the question as such is asked as antifungal therapy, you can start off with the classification of antifungal therapy. It's already been given in all the pharmacology textbooks itself. You can go about through that, and then followed by each drug, what is the dosage and how, for what is it being indicated. Even if you can specify about the mechanism of action for each of these drugs, you can gain marks related to that question. So we can go about to this flowchart itself for management of oral candidiasis when the question has been asked related to that. Next, the question is related to enumerate the keratotic white lesions of the oral cavity, then followed by discussion in detail the etiology, clinical features, differential diagnosis, as well as the management of oral leukoplakia. So this is also a similar question that has been asked previously in the previous slides itself I have explained. So if you are asked about the keratotic lesions to be enumerated, you can go about with the same classification, that is scrapable as well as the non-scrapable lesions, and then you can enlist the keratotic lesions, that is the non-scrapable ones, which has been highlighted in this tabulated form. You can go through that. And then again, when the question of asked of leukoplakia etiology, in the previous slides I have not put the slide as such for the etiology. You can go about in this slide itself that etiology of leukoplakia, it is nothing other than the tobacco usage of patients as well as the alcohol predisposition can lead to this condition. Even some cases due to trauma, that is especially mechanical trauma due to any sharp tooth or any crown margins, that can cause an irritation towards the mucosal surface or the mucosal lining of the any of the tissues. You can see that it can lead to this condition. And there's also pre-malignant epithelial changes that can be seen. It is also found to be associated with Candida albicans, UV radiation, and also I've previously mentioned about trauma, as also in cases of regular intake of toothpaste or mouth rinses. That is found to be the rarest of the rare cases itself. Clinical features I have already mentioned in the previous slides itself. Most commonly it is a white plaque kind of a lesion, and it's a non-scrapable lesion, and you can say that there is a cracked mud appearance that is seen especially around the buccal mucosa, then the alveolar mucosa, floor of the mouth, lateral borders of the tongue, lip, and the palate region. And there are also subtypes for the leukoplakia, that is a homogeneous and the non-homogeneous leukoplakia. These are the common sites that have been cited for leukoplakia. Next question to that is being asked about the differential diagnosis of oral or the Leukoplakia as such. So once the differential diagnosis is asked, it will be most preferable if you can write it in two columns itself. That is, yeah, one side you can state about the Leukoplakia, what are the features that you see, and then the differentiating factor with the differentiating condition that you can give. That is, here it is enlisted with the lichen planus. Especially when you're talking about a homogeneous Leukoplakia, you can give a differential diagnosis of a reticular type of a lichen planus or a plaque type of a lichen planus. But what is the differentiating factor with the lichen planus to that of the homogeneous Leukoplakia is the Wickham striation that you see. That's a classical appearance that you see in lichen planus. Then followed by next is the frictional keratosis. Frictional keratosis, again, it can be just a linear white plaque or a patch that is seen, especially around the posterior buccal mucosa, because of the reasons due to that is caused due to the present chronic irritation towards the irregular or the sharp cusps. It can lead to this present condition called as frictional keratosis. And then the next condition you can think of is a chronic hyperplastic candidiasis. Again, you can enlist what are the reasons. If they have specifically given marks for like around 3 marks for differential diagnosis as such, it is always preferable you can put in points for each of these conditions. That is the lichen planus, then the frictional keratosis, then the chronic hyperplastic candidiasis. You can write the highlighting features to differentiate that from Leukoplakia. So followed by next as a leukoedema, white spongy nevus, which is a white spongy nevus is found to be a hereditary disorder. So all these can be enlisted, and you can give it as a site for the differential diagnosis for Leukoplakia. Then again, this have also been explained about the management of Leukoplakia. Give a tabulated form or the flow chart to state how to go about for the management or the treatment protocol for Leukoplakia conditions. So you can emphasize after this, you can give a 3-liners for what are the drugs that has been given for Leukoplakia. Especially you give immunomodulators and also some corticosteroids and some alternative therapies such as that of retinoids are being given, even lycopene is being given. All these can be emphasized with a mechanism of action for each of these drugs, and then what is the dosage for it. That can be highlighted under the management of Leukoplakia. So this management you can read from the textbook of oral medicine by Ravikar Ongol itself. Even in textbook of oral medicine by Anil Gomes, they have also emphasized about the treatment protocol for each of these white lesions. You can go through those 2 textbooks. Moving on to the short essays that have been frequently asked under this topic, that is oral thrush. Oral thrush is nothing other than the other name or a synonym for pseudomembranous candidiasis. You can say, I have already explained in the previous slide about what is pseudomembranous candidiasis. It's nothing other than a white or a curdy white kind of an appeared scrapable plaque-like lesion that you see, which once you scrape out the plaque, you will see it is left behind with an erythematous area, and is found to be a most common form of oral candidiasis. And you can explain about what are the clinical features as well as what are the etiological factors leading to this condition. Then again, this is a favorite question. Most of these white lesions, especially lichen planus, Leukoplakia, OSMF, that is oral submucous fibrosis, can be asked frequently as a short essays itself. Most of the times they ask about the management part of it. So if you can go about reading these 3 lesions, that is lichen planus, Leukoplakia and oral submucous fibrosis, will be self-sufficient to gain marks for these questions when asked. So I have already explained in regard to lichen planus, especially when you talk about it. We start off with the age predilection, then the gender predilection, and what are the skin lesions that you see in lichen planus. There are certain 32 types of skin lesions, and the 6 P's that I've already mentioned in the previous slides itself, that you can go through it, and also the 6 types that you see in your oral manifestations or the oral types of lichen planus. That is, all the 6 types have to be explained with the clinical appearances itself. And this is the management or the treatment protocol, the flowchart that you have to go through about and read about it. Read about all the drugs as well as the mechanism of action and the dosage of it, so as to get marks or gain marks for this question. Next is the question that can be asked is the erythroplakia. Erythroplakia is nothing other than a non-homogeneous leukoplakia itself, wherein there is found to be a more predominantly reddish appearance. It's a red lesion. So the clinical features that you can talk about is there is a red macules or plaque which has a soft velvety like texture that has been seen. The most common site for erythroplakia is found to be around the soft palate, the floor of the mouth, buccal mucosa, and it rarely affects the tongue. So this is also to be considered of a malignant transformation too. So we have to do the treatment as soon as possible itself. If possibly you can excise the lesion, that will be self-sufficient, and then again we have to do review for such cases. So as I've explained, the erythroplakia, it's found to be a red macule or a plaque-like lesion with a soft velvety kind of a texture, as you can see here, a reddish plaque like lesion. And over this, in this lesion, you can see that it's a tongue portion itself. You can see an exophytic or an outgrowth that has been seen within the lesion itself. And commonly it is found to be occurring at the elderly age group and the middle age group, and there's a male predilection that has been seen for erythroplakia. Once the question is asked about the management of leukoplakia or erythroplakia, this is the flow chart that has been given in Burkitt's oral medicine textbook itself. You can go about through this and write and emphasize about each of these protocol itself. Now next questions are about the short notes. Short notes that can be asked is biopsy. Biopsy as such, there's a total different chapter for that itself. But once a question is asked about related to biopsy, you should explain what is biopsy. That is surgical procedure to obtain a tissue from a living organism for its microscopical examination to perform the diagnosis. So we take a tissue from the surface or a suspected lesion, and then we undergo a certain histopathological examination to gain a report of what is the histopathological diagnosis that you can be drawn for after the biopsy is being taken. So there are types of certain types for the biopsy. That is a surgical biopsy, FNAC, that is a fine needle aspiration cytology. Then you have the brush biopsy, frozen section biopsy, cone biopsy, and the laser biopsies. So you can highlight each of those biopsies. You can draw a diagram related to this, what is a biopsy and all that you can see here the diagrammatical representation of what is a biopsy. And then you can speak about emphasize of what are the indications for all these types. It's already been given in the textbook of oral medicine by Anil Gomes itself. He has emphasized about each of these types and what are the indications and the contraindications, and how do you go about for each type of biopsy to be taken. Now, what is the methodology for that? So if it is asked in a short essay, you can emphasize and elaborate about it. If it is asked for a 3-mark or a 4-mark question or like a short note, you can just mention what is biopsy and what are the types of it, and you can draw a diagram like how it has been presented here. Next is the toluidine blue vital staining. This is a favorite question to be asked under the vital staining topic. This is a chairside investigation method, and you can mention who discovered this vital staining, that is by Nabel and Comet in 1964. And this was used as a early detection of oral precancerous as well as malignant lesions to be detected. These are the vital stains that have been used, and the indications for these toluidine blue vital staining is to adjunct to the clinical examination as well as the biopsies, and it's found to be a basic metachromatic dye. And what it does, what is the function or the mechanism of action of this toluidine blue staining, is that it stains the acidic tissue components as well as it binds to the readily cited DNA proteins of this malignant lesion. So once you try to after application of this toluidine blue staining, you might see that the malignant cells will intake a navy blue or a dark blue appearance under the normal light. So once that kind of a significant color change has been noted down, it states that there is a pre-malignant lesion or pre-malignant cells are appearing within the tissue. So this is how you go about with the technique of toluidine blue staining. First and foremost, you cite the suspicious site or the lesion that has been suspicious around, and after that you ask the patient to rinse their mouth and with water, and then followed by rinsing with the acetic acid, and then followed by the application of the stolidin blue dye over the site of the region of interest, and then after that again we rinse with the acetic acid, and then we go about with the examination of that lesion. If the lesion takes up this navy blue color or a dark blue color, then it states that there is significant premalignant cells seen within that lesion. So this is the methodology that I've explained earlier, how to go about. Next question we move about with the oral submucous fibrosis. Once this question has been asked, definitely you have to give a definition that is given by Pinborg and Sirsat in 1966. The definition goes like this, that is, it's an insidious chronic disease affecting any part of the oral cavity and sometimes the pharynx, although occasionally preceded by and or associated with vesicle formation. It is always associated with juxtaepithelial inflammatory reaction followed by a fibroelastic change of the lamina propria with epithelial atrophy, leading to stiffness of the mucosa and causing strabismus and inability to eat. This definition you should know somehow, because at times even for your practical viva this question can be asked. What is a definition for oral submucous fibrosis? That has been given by Pinborg and Sirsat in 1966, and at the same time they can you can refer this definition. If not here, you can refer it in the textbook of oral medicine that is given by Ravikiran Ongol. He has given the definition for this. So the clinical features that you see in oral submucous fibrosis, it is most commonly seen in the Southeast Asia, especially India, and the age predilection is found to be around 12 to 62 years of age, and the mean age is found to be around 40 years, and there is a more of a female predilection. The symptoms that you see in such patients is the burning sensation, as well as they see this kind of a whitish kind of a blanching of the oral mucosa that has been noted down. Especially pallor is seen around this site of affected site. And then this common sites that are seen for oral submucous fibrosis is the buccal mucosa, the retromolar area, then the soft palate, palatal fosses, facial palates and facial pillars or the palatal fosses. Then you have the uvula, tongue, and the labial mucosa. It's been given in the textbook of oral medicine by Ravikiran Ongol itself. You have the types as well as a classification of OSMF that has been given and it's been enlisted in that. You can go have a read through that. And what are the clinical appearance that you see in oral submucous fibrosis is that there's a stiff tongue and a small or a stiff tongue or a microglossia will be appearing, as well as you can see a blanched or a leathery floor of the mouth has been appearing. And the first initially it starts off with a vesicle, and then it forms all these kind of fibrotic bands have been seen. Especially in the advanced stage of oral submucous fibrosis, the patient will have trismus. There will be fibrotic bands that are seen around the bilaterally of the buccal mucosa, and then you can see that there's a rubbery soft palate, decreased mobility, blanched out facial pillars, and then a shrunken bud like uvula. You call it as a hockey stick appearance you see in uvula. And then you have, as I said earlier, the trismus. You can also see that there is other symptoms such as that of salivation and also hearing loss and the dryness of the mouth. Then you have dysphagia and also improper or improper functioning of the normal mouth movements, such as that of opening and closure has been disturbed. Then next is the investigations. How do you go about for investigations for oral submucous fibrosis? Initially we go for an incisional biopsy around the site of interest, especially near the fibrotic bands. Over there itself we try to incise, and then we go about with the histopath reporting. And then you can see all those juxtaepithelial changes or the lamina propria changes that have been noted down in the connective tissue area, and through that we can suspect a oral submucous fibrosis itself. And then other serological and the immunological hematological examinations that have been done, you can note where it is notified that there is an increased erythrocyte sedimentation rate, that is ESR has been increased. You can see a slight eosinophilia, microcytosis, anemia has been noted down. Now in cases of treatment of OSMF, this flowchart has been given by Ravikiran Ongol himself, and you can go about how each stage where what has been indicated for treatment plan itself. So you can say that in stage 1, that is a mild or the early stage itself, you can prescribe some topical applicators such as that of the benzodiazepine or the tantum oral rinse, that is the trade name that has been given for prescribed for mild conditions, and then followed by the moderate conditions such as the intralesional injections have been given. It's a cocktail of drugs that has been given, such as that of the corticosteroid, that is the dexamethasone, along with hyaluronidase, then with the placentrex also, along with lignocaine itself. It can be combined together, and these injections are given towards the fiber bands itself, so that it loosens the fiber bands by the process of fibrinolysis. So that is by destruction of these collagen fibers, the fibrotic bands. It loosens up these it loosens up the fiber bands itself, and then what happens, it helps for the patient to slightly open their mouth. So that when there's a limited mouth opening, it helps to increase the mouth opening itself by giving these intralesionals itself. So these intralesionals are given maybe bi-weekly, or a single dose is being given weekly wise for around 6 weeks itself. So you can see the changes, and we notify those changes every review when the patient comes back after the interlesions are being given. So then even in the advanced stages, we have no other choice but to go for a surgical excision of these fiber bands itself, and then we go for a laser surgery itself, and again we go through the physiotherapy sessions, such as that of asking the patients to slightly open their mouth with the help of these ice cream sticks that you get. You try to place each ice cream stick one by one over the other, so that the patient can slightly open their mouth, and there's kind of functional there's no such functional deformities occurring by limited mouth opening itself. So, and then it will ease their chewing mechanism as well as the swallowing and all. So all these kind of physiotherapy sessions are being advised for such patients. Then you can go about for the newer drugs that is being given, that is being prescribed, that is a pentoxifylline drug, as well as interferon gamma injections have been indicated for such cases, so that these patients are having no issues with their mouth opening, or any trismus is being eradicated in such cases, and more normal functioning occurs. Next question that can be asked is the treatment of oral lichen planus. In oral lichen planus, already I have explained about this in the previous slide, how to go about. Please make a point to draw this flow chart, and then each of the drugs that has been enlisted in this flow chart itself, you have to mention what is the drug that has been utilized and what is their mechanism of action, and then followed by their dosage that has been prescribed for each. So if you explain all these things, definitely you can fetch marks, and you can score well for your exams also. So thank you, and I will be continuing with the discussion in regard to the question papers in oral medicine and radiology. So stay tuned. Thank you so much.